Some facts. Psychiatric disorders are expressed by behavioral symptoms, as you all know, and this behavior may be dangerous to the patient or other and or against the law. And psychiatric treatment may stop the problematic behavior. Some patients have no insight and refuse treatment. And hospitalization is perceived by physicians, not just psychiatrists, as a tool to provide treatment and to promote health. We don't see it as... You're all familiar with the WHO Madrid Declaration from 1996, and then it was repeated in 2004, and accepted by the WPA subsequently, that psychiatry is a medical discipline concerned with the provision of best treatment for mental disorder, and psychiatry should devise therapeutic interventions that are the least restrictive to the freedom of the patient. That's very clear and agreeable. And still, in most countries, the way to do this, the treatment for those patients who are not interested in, is in compulsory treatment. Usually, the criteria, that's in Israel, but in most countries, are mental illness that impairs the ability to make decisions or to judge reality. In my country, it's interpreted as psychosis. And the other one is immediate danger to himself and his surroundings. Also, not immediate danger that there's 24 hours. And there is direct link between illness and danger, because if the guy is doing something like stealing, it's not because of the illness, and the patient refuses to be examined or hospitalized. The same is in the U.S. As the Supreme Court in the U.S. said, the finding of mental illness alone cannot justify the states of confining persons, and they must be also considered dangerous to themselves or other, or unable to take care of themselves, that they cannot survive outside. That's reasonable. However, there are very big difference between the laws in different countries. In most European countries, there is a special Mental Health Act. There are no special acts in Greece, Italy, Spain, or in our South European countries. And the main reason for not issuing a separate Mental Health Act in those countries is to avoid stigmatic effects when separating rules and regulation for mentally ill and for general health care. It may increase the stigma. Now, if you look at the numbers, and I looked at the numbers for the last couple of days, they're very, very different. For instance, in Italy, 5% of admissions are involuntary. In UK, it's 50%, 10 times as much. In Israel, it's 30. There is no correlation with number of beds per population, number of staff, nothing. Remember that. It's very, very diversified in each country. I'll say it from now. It's mainly because where's the balance or how we apply the law. So this is, and it cannot be comparable, as I will show you in a couple of minutes. And still, even if it's in Italy 5%, and we're trying by law to limit the forced hospitalization, we get very severe criticism with psychiatrists. If it's from the World Health Organization that said there is call for a global emergency of human rights violation in the mental health system. The violation is you, us. And only recently, in 2017, last year, there was a UN report on the rights of mental health patients, emphasizing that we are more into biological treatment, that they forgot the psychosocial treatment, not the psychiatry, right? And informed consent and coercion, that we close patient unjustifiable. And Silvana Goldarisi, which is the chairman of the EPA, has had to justify it, and we all wrote that how it is in our countries, but still, whatever we do, we get criticized by society, and WHO is physicians. Now, why is this criticism? Who is to decide which patient has to be admitted involuntarily? Well, severe mental illness, we psychiatrists, we know to diagnose psychosis, we know to diagnose mania, we know to diagnose behavior due to the disorder. Dangerousness, it's a very problematic concept, and we are criticized. For instance, the UN report has a whole section on dangerousness. They say, well, they don't know what they're doing. How can they predict dangerousness and close people just because they think that they may be dangerous? And I think there is some point here, because we are doctors, we are not prophets. I haven't studied prophecy in medical school, neither you, and we don't know the future. What we do know as doctors is that the best predictor of future violence is past violence, old saying, and nothing predicts behavior like behavior. That's very simple. What you see is what you get. What things will not change probably. It's not enough for the judge. Now, what we know odd ratios. We know that people who smoke have a greater risk to have lung cancer. However, most people who smoke are not having lung cancer. So we cannot diagnose lung cancer just because somebody smokes. We know that if somebody is suffering from schizophrenia, the odd ratio is 7 times as much to be violent. If it's schizophrenia and alcoholism, it's 25 times. However, but what is important here is this. If a person committed homicide offender, whether he is a forensic psychiatric patient or not, his risk to repeat the crime is 250, 300 times as much. So, in other words, whether it's a psychotic patient or not a psychotic patient, if he kills his neighbor because he thinks that the neighbor is watching him, that's an tendency for being violent, not necessarily the disorder, and you should keep it in mind. We are not talking very nice, helpless people necessarily. Now, there is a balance, and I go through it very shortly. There is a balance between 3 ethical issues. You all know it. I'll just emphasize the important points here. One is the patient's right to receive medical care. As many people call it, duty of care. State, one of the duties of the state is to take care, is to supply care, whether general health, psychiatric health, education, police protection. So that's one of the rights, of the positive rights that a patient has to get. Now, it sounds very simple. Not necessarily. The society still is thinking in a double message manner. For instance, a very, I think, typical example, the chairman of the Supreme Court in Israel, it's called Aaron Barak, a very knowledgeable person. When he was on duty as chairman of the Supreme Court, he was very much into the protocols, procedures, and he criticized psychiatrists in several applies for not behaving according to the regulation and procedures and discharge the patient. Now, he retired a couple of years ago. He's not in charge anymore, and he wrote a long paper recently stating that, talking about the right for life, health, and respect of the patient. It's totally different thinking from the same senior, influential person. As they said, you stand depends where you sit. He was not sitting in the Supreme Court anymore. He changed his mind. So the patient right to receive medical care is not an easy thing. Now is the personal right that we all agree about. Dignity and liberty, everybody has the right to be free and not to be in a closed world. Well, many people will ask, and you are familiar with that, has a patient, while he's in acute psychotic state, dignity or a real freedom of choice being controlled by voices who order him to do things, or obsessions, or beliefs, or delusion of persecution? Is that freedom? Or being in mania? I'll just give you a little example. A colleague of mine who was a professor in law, at School of Law in Tel Aviv, he became manic, very manic. And when he was manic, he went into lectures of other professors, disrupting, and said, you don't have to listen to those people. You have to remember only one name. It's my name. That's a shame. Not nice. And a friend of mine brought me and said, how can I help him? I said, well, he doesn't want medication. So he said, well, the best thing is to hospitalize him. And if not voluntarily, so it's better to do it involuntarily. They never wanted to hear about it. The end was that he was hospitalized, I think voluntarily after a time. But by then, he lost his job because he cannot go back to teach after this behavior. So, what's more important? What's the respect? Did he have a choice? He's a normal person, but when he was manic, he really thought that he's smart and everybody, and forget the dean, forget everybody. So they forgot him. So that's just an example that sometimes the damage for keeping somebody's freedom and liberty and dignity, in fact, is the opposite. No dignity in being manic, no dignity in causing harm and with no ways back. We are not that much tolerant to behaviors like this. And then is the more painful issue of protecting the public and families, or even the person himself. And as you know, in every country there is the civil versus the criminal compulsory treatment. Civil, when the patient didn't break the law yet, and criminal when already he did. Now, the borders are very, very diffuse. For instance, if a patient is threatening or pushing his mother when he's psychotic, if the police decides to arrest and open charges, he will be on the criminal track. If the policeman thinks, well, he's crazy, let's take him to the ER, he will be on the civil. And when they will say, how can you close it? Is it dangerous just to push his mother? He did nothing, he was just pushing his mother. It's not that simple. If his mother is 120 kilo, it looks, well, that's nothing. If his mother is 60 kilograms, she could fall and die. So where are the limits? Now, so for the same behavior, sometimes the patient can come on a civil track, and then he is prone to regulations and rights. The same patient, same behavior. When it comes on the criminal, he has less regulation, less rights, and people understand that this is already danger. I'll just show it in another example. You can see this is compulsory admission in Israel. It's around 30%. 20-something is civil, and 8% now. It hasn't changed since then. is on criminal. What is important here, that in 2006, here, there was a new regulation that every patient who came in with as compulsory civil admission has the right to have a lawyer, an attorney, young people who are fighting for him, making it much more difficult. So it's much more difficult now, and that's why you can see from 2006 a big increase by the court orders, because some patients are not qualified anymore for civil; they qualified for court order, and you can see here in the next one that what happened. That one happened when the legal defense was. There was a drop in the civil orders and increase in the court. It's the same patient. And just an example, one of our patients was discharged by the committee, and they got home, and after 1 hour, the mother called and said, he's really violent at home. And I said, well, the court decided that he is okay. We have nothing to do. And then I did something that we're not supposed to, and I gave her the phone of the lawyer, called the lawyer. That's not...
These inpatients are in the psychiatric hospital or in the ward?
Psychiatric hospital. In psychiatric hospital, she was discharged because the dangerousness was not clear enough. So obviously, she came. The mother had to call the police, and she came again through the criminal. Okay. Now, so this is the balance of rights, and as you can understand by now, every country has to decide where the balance, how you do it. Is it the doctors, the judge, the mayor, or is it here the police? And it varies from country to country. However, there are some problems from our clinical point of view, which I want to point out now. Over the last couple of years, there are some papers showing that involuntary admission and involuntary community treatment are not that effective. This is one study showing that long-term effect of involuntary hospitalization and on medication adherence, treatment engagement, and perception of coercion are not relevant, and there is no difference if between patients who were on involuntary admission or not, checking the blood levels. So they conclude that being a cause to treatment and they still are not adherent, and there is no much difference in the future. And I'll show you some other. That's another research showing that patients who are discharged under community treatment order, their prognosis is not much different than treatment as usual, and after 6 months, and no parameters are changed. They're coming back to hospitalization as before. That's another study showing that all interventions to reduce compulsory psychiatric admission in fact are not that effective, and especially community treatment order is not effective to prevent future admissions. The only intervention that is advanced statements, advanced directive and crisis plans, and maybe community treatment. Those two are effective. Treatment in the community is not effective, That's another showing that there is no difference between treatment and usual and the order. And summarizes that compulsory community treatment results in no significant difference in service use, social functioning, or quality of life comparing with standard voluntary care. Well, that's a conclusion. However, it doesn't hold for any specific patient. Next. And one of the reasons that treatment orders in the community for psychiatric patients are not that efficient is that all societies are not very clear and decisive about that. And they don't enforce the law. For instance, in Israel and other countries, there are treatment for contagious diseases. When somebody is suffering from a contagious disease, they want people they don't want that it will affect other people. So a judge of a lower court may, upon a request of the publicly employed doctor, issue an order to transfer the individual immediately, and they don't have problems with that. Our patients are perceived as people who are not that responsible. We cannot take them by force. Let's give them a chance. So I think that's one of the reasons. Now, it's even more difficult, and I'll not get into it, even much more difficult is to predict suicide. We attempt, or we think that we can predict suicide. The reality is that we can't, because the relation of attempts or ideation to suicide are very big. Suicide is a very rare event, and if you want to predict, there's always false positives, and our prediction is low sensitivity and specificity because of the rarity of suicide. Even when there's depression and even when there are some risk factors. We know risk factors. We know risk factors for heart attacks, but we cannot really predict that the patient will get a heart attack in the coming years. I'll not get into this. You have this John Powell on the British Journal. He made the calculation that in his hospital, from 8,000 patients who from the ER, 25 are compulsory hospitalization, 1,000 are because of a suicide attempt or ideation, and the calculation shows that we have to hospitalize 999 patients in order to prevent one suicide. It's so much false positive. And the question is, as they said, never in the history of medicine have so many been hospitalized to protect the few. In other words, we cannot predict suicide. However, if patient is committing suicide and we have done nothing, we are sued, and we don't feel that we did our duty as doctors. So just remember this: whatever we do is wrong. If we hospitalize a patient, they say, "Why did you hospitalize him? There are so many people with depression." And people commit suicide in hospitals too. But if we don't, we are sued. But we cannot predict. Our prediction of suicide is very, very, very poor. And I think I have a very good summary of 2 minutes. One minute. And a very good summary is by the Italian paper by Barbui from a recent paper that shows that in Italy, for example, psychiatric beds decrease, number of compulsory admission decline, suicide rate remains stable, and there is no beds, no staffing, and still everything is fine. So there's no correlation whatsoever, and that's a very good example to show us. The same goes with physical constraint. It's bad. It's bad to tie people to the bed. However, the other possibility that will violate other people's rights, attacking other people or attacking staff. So what's the solution? Either have much more staffing, or, as I asked the UK, rapid halidalization, extrapyramidal. Is it much better? I'm not sure. I'm not sure that it's better. It's very nice to release people from the salpêtre-touillère, very populistic, very time appropriate, not always it can be done. So, in conclusion, two last slides. What can we do to reduce involuntary admission? Empowerment of family physician. They can do much better to help us. Advanced directive and crisis plans in the community. What to do, special staffs for crisis, to be there. Psychiatric wards in general hospital, as it is here, to reduce stigma. Patients always prefer to be in general hospitals than in psychiatric state hospitals. Then we have also to increase the budget for mental health. Nicer hospitals, that they will not look like, I've seen the pictures before, more staff, more nice, so it will be less trauma, people will be less afraid. So the last slide conclusion, I think that involuntary hospitalization can be life-saving and prevent tragedies sometimes, although it's problematic state. The use of physical restraint should be reduced as much as possible in a cost-benefit manner. Everything here is a cost-benefit manner. And clinical, social, political, and legal factors all have an important role in the compulsory treatment dilemma. Thank you.